All right, good afternoon, I'm sorry, it's actually still morning. Good morning. I'm Dr. Dale Bratzler. I'm the Enterprise Chief Quality Officer for OU Health and the University Chief COVID Officer. Let me just go through a handout that will be distributed that highlights some of the data for COVID-19 in Oklahoma through the week. The State Health Department just released data for today, so we're up to over 160,000 confirmed cases in Oklahoma. 2,921 new cases that were reported just today with 15 additional deaths. So if you look at our total counts for the week, it's actually pretty scary. We're just under 20,000 new cases in Oklahoma this 1 week, and 110 Oklahomans have lost their life this week. If you look at the trend lines for both the 3-day and the 7-day rolling average, they're both still trending upwards. In other words, we're not bending the curve yet. The number of cases is still going up. We actually have 2,843 new cases every day in Oklahoma on average based on the current data. If you look at the data on rural transmission of the virus, sadly we're seeing very dramatic increases in the number of cases in many rural counties. And while they have relatively low populations, some of them have seen a third of their entire case load since the start of the pandemic within the past week. So it's spreading rapidly in many rural communities. If you look at testing in Oklahoma, of course, I think many know that at individual county health departments and many sites, they're seeing rates of positive tests that run from anywhere from 15 to 30%. But if you look at all the specimens tested in the state, right now we're running around 15% of the tests that are being done are positive. Finally, I think we're all aware that the hospitals are really getting very full. We had 1,438 people in the hospital with COVID-19 yesterday, which is the highest rate that we've seen since the onset, highest number of people in the hospital since the onset of the pandemic. 1,358 with confirmed cases. 30% of those people were in the intensive care unit. So we're still seeing rapid community spread of COVID-19 in Oklahoma with a big impact in rural communities and almost 3,000 new cases every day on average right now. Just a couple of points. I threw in a couple of studies that I think are important to understand because they have an impact on thinking about what's happening with respect to COVID-19 in Oklahoma. So I threw in a couple of graphics from the Institute for Health Metrics and Evaluation. And again, many of my colleagues now feel that we're almost inevitably going to overload the hospitals in Oklahoma in the relatively near future. Just consider the fact that we had 20,000 new cases of COVID-19 in Oklahoma in the past 7 days. And typically 10 to 12% of the people who test positive end up in the hospital. So we could see an additional 2,000 people in the hospital over the next week or so. And though some patients will go home from the hospital, I think the pipeline of new cases into the hospitals is bigger than the pipeline of people that are actually getting to go home or leaving because they don't survive. So I think we're going to see substantial increases in the number of people in the hospital. And indeed, if you look at the Institute for Health Metrics and Evaluation, their data, they suggest that by the week of Christmas, we'll have 1,000 more people in the hospital than we do today. And by the first week, at the end of the first week of January, we could have a doubling of the number of people that are currently hospitalized in Oklahoma, which means that we're going to have to limit other activities unless we see a substantial drop in the rate of growth of new cases in Oklahoma. A couple of other studies I thought were interesting. One, I put 2 slides in the handout that will highlight a study that came from the Centers for Disease Control in the University of Michigan that looked at 1,600 patients that were hospitalized with COVID-19 in 38 different hospitals in Michigan. This was a study done near the start of the pandemic, so it looked at patients from about March through the end of June. But the interesting thing that they found was that 1/3 of the patients who were hospitalized in that time frame died from COVID-19. Many of the people who were dismissed had ongoing physical emotional, and financial impact. 40% of the people who had been hospitalized with COVID-19 did not immediately go back to work. So there's very substantial financial impact of having a lot of people that are sick with this disease. It does have a substantial impact. They followed these patients for 60 days. If you look at the 405 patients that were in an ICU, 60% of them died within 60 days. Although we know now that in the United States, the mortality rate from COVID-19 in hospitalized patients has come down fairly substantially, at least a 30% reduction, but still a lot of people that get that sick that are in the hospital with COVID-19 don't survive the illness. Another study from Oregon and Washington State looked at patients with severe influenza and patients with severe COVID-19. And what they were doing is comparing the outcomes of the patients that have severe disease. And in that particular study, the death rate was twice as high from COVID-19 as it was for severe influenza. Another study that looked at data from the Centers for Disease Control looked at death rates in the 25 to 44-year-old age group in the United States. And in several areas of the country, which included Oklahoma, COVID-19 now has become the most common cause of death in that 25 to 44-year-old age group, even more common than opioid overdoses. Now, in Oklahoma, we've been spared, it looks like. We've had very low death rates in our younger people, but if you include the other areas that are in that region of the country, Texas, Louisiana, Arkansas, Oklahoma, the death rate is up substantially, even in younger people. Finally, I just want to highlight each day the health department reports the number of active cases. And so right now we're somewhere around 30,000 active cases if you look at the data that's reported by the health department. That's people who have tested positive, who are not in the hospital or still in the hospital, but they haven't gotten past 14 days since the positive test. In other words, it's people who could potentially still be infectious. There were two studies that came out this past week that highlighted that that's a gross underestimate of the number of people in the community who are infected. In fact, two different studies that came out suggested that there are more than 3 million people in the United States who are currently infected, who could spread the virus, many of whom don't know that they have COVID-19. They're either asymptomatic, pre-symptomatic, or they just didn't get sick enough that they even went and got a test. And so one estimate suggested that up to 1 in 100 people in the United States could be infectious. And so just remember, anytime you're around any size substantially of a crowd, there is some risk that there could be somebody in the crowd that's infected.
All right, well, we have quite a few questions, so we'll wade right into them. Are the new restrictions from the state enough to slow the spread?
Well, so I think some of the new restrictions that have been put into place may have some benefit for reducing spread of the disease. But honestly, I think quite honestly what we're seeing now, we saw 20,000 new cases in the past week, knowing that there are a large number of infected people in the community that are still shedding the virus and will spread the virus. I think it's too little, too late right now. Many of the health workers that I talk to and experts around the country feel that we've crossed this point where inevitably we're going to see a very substantial increase in the number of people in the hospital. Even if we got every Oklahoman right now wearing a mask every day in any public setting, reducing some of their indoor congregate activities, I think it would be 2 to 3 weeks before we would see a substantial impact of some of those interventions. So just remember that it does take a while for public health interventions to take effect, and we have a large number of people out there right now who are infectious and spreading the infection.
How do those restrictions compare with other states?
Well, I think there's considerable variation between states in the number of restrictions. So over the past couple of weeks, we've seen states like North Dakota, Utah implement some much broader restrictions because of the spread of the virus in those states. I think that's one of the sad things for public health right now, is that we don't have a unified national approach to actually addressing the pandemic. because we know people cross state borders, we know that people are mobile. The reality is that the virus is still spreading. If you look at any map of the United States, the Midwest is being hit particularly hard right now, and there's substantial community spread of the virus that's not checked by current interventions.
How long will it take for these restrictions to be effective?
Well, most of the time it suggests that if you implement public health restrictions, most of the studies that I've reviewed have suggested that you don't see much impact for the first 2 weeks or so after they're implemented. But once you get past 2 weeks, you start to see some of the impact of some of these restrictions. We saw that as we started comparing in Oklahoma, those communities that had mask mandates to those communities that did not. And there was typically about a 2-week lag between implementation of a mandate before we started to see some improvement in the numbers.
Can you speak to how contact tracing is going, and are they able to keep up with all the new cases that we're seeing?
So the questions about contact tracing and are they able to keep up, I haven't talked to anybody in the last few days. I know that the resources for contact tracing have been stressed. Again, think about 20,000 new cases in 1 week in Oklahoma, and then think about not only contacting each of those people, but also contacting and talking to each one of their close contacts. And so the numbers now get very, very large for the number of people that have to be communicated with. And honestly, I believe that we've gotten to the point in Oklahoma with the spread of the virus that we're beyond the strategy of containment of the infection. I think we have to do more to do mitigation, and that's what the governor did this week by implementing the mask requirement in state buildings, shutting down bars and restaurants at 11 p.m. to try to start doing mitigation, start trying to slow the spread of the virus. I've talked to contact tracers. I know they're increasingly having difficulty getting people to respond to them, to answer the phone. Some have told me that about 40% of the cases that they try to contact, they have very great difficulty getting a hold of. And then people, frankly, know that if they tell a contact tracer that somebody was a close contact, that they are going to be put into quarantine, and I think that's limited some of the cooperativeness for people that have been a part of that.
Has OU Health made any changes to the visitation policy?
Yes, OU Health, I believe it's been announced now, has gone to no visitors in our adult hospital and only one in our children's hospital, with just a couple of minor exceptions, obviously people at the end of life or people who are important caregivers of a person who's not competent to take care of themselves or not competent to answer questions. We do allow a visitor in the adult hospital in those settings. We have strict rules for visitors. If somebody does get to come in, they have to be in a mask continuously. They have to stay in the patient's room. They can't be in the hospital because, again, we know that there are many, many people in the community right now who are infected and could spread this virus.
How do doctors feel about school districts planning to return to in-person learning with the current surge in COVID cases, especially after the holidays when we expect to see higher numbers? How can districts justify returning to in-person?
Yeah, so let me answer the question two different ways. I think it depends on the age of the student groups that you're talking about, because younger children, particularly those less than the age of 10, don't seem to get infected as often and certainly don't have complications of the disease. And the data is really mixed on how much transmission from kids to adults actually happens, particularly with young kids. Once a child hits age 10 or so, though, then they start acting more like adults with respect to the rates of infection and their ability to spread the infection. So there may need to be a look at different policies depending on the age group of the students that are actually being affected. I know the American Academy of Pediatrics and many other organizations have highlighted that there is a toll on students not having them in the classroom. I completely understand that. And my point is that if our goal is to open up schools in January, to get people back to school, to change the map, the color of the map, then we need to do much more right now to make that happen. We have to get people universally wearing masks in Oklahoma. We have to ask people to physically distance themselves, to avoid settings where they're indoors with people, particularly in settings where people are not wearing a mask, because that's how the virus is transmitted right now.
Without a statewide mask mandate, why should communities move forward with mandates? And are there any other ways people can help slow the spread and protect themselves?
Well, so I give great credit to those communities that have put mask ordinances into place, because we have good data, Oklahoma data, that shows that those communities that do mandate masks have slower rates of growth of new cases of COVID-19 than those communities that have elected not to put mask mandates into place. So in the absence of a statewide mask mandate, I strongly encourage communities to consider it and put mandates into place, because it works. It reduces the number of cases of patients who end up in the hospital. And I think one of the things we do not talk about enough is the economic impact of COVID-19. We understand that if you close businesses down, restrict businesses, that has an economic impact, but I will tell you that there is a substantial economic impact of those people who get infected, who end up in hospitals, who have difficulty returning to work, who have long-term disability, high medical bills. We're paying for it. We're just paying for it in a different place. So if we want to get our schools open again, I think we have to be much more aggressive about the mitigation strategies which have been shown to reduce the spread of the virus.
There have been some studies that question the effectiveness of shutting down bars at 11 o'clock because people might just gather in homes. What are your thoughts on that?
Well, I think the time frame of 11 o'clock is a bit arbitrary. It's my understanding that some people think that perhaps patrons in bars after 11 p.m. Aren't as likely to socially distance or get less vigilant about some of the things like staying separated, wearing masks, and things like that. My perception is if you drive down through Bricktown or other areas that are popular at night, 11 o'clock is too late. Many activities are going on well before that. And I think, again, if you have people indoors without masks, that's where transmission occurs. Time's going to tell us. Within a couple weeks, we're going to know whether these new activities have had any impact on the transmission of cases in Oklahoma.
What would you say are the least and most risky holiday activities?
Well, perhaps the most risky is pulling together a large family, multi-generational, grandparents to kids, sitting around a dining room table where you don't have your mask on, talking, so now you're in close proximity to each other and you don't have a mask on. If there's somebody at that table that's infected, there's a very good chance that others at that table will get infected. As we know, the patients who are older, who have chronic conditions, those are the patients who suffer the consequences of COVID-19. They're more likely to be hospitalized and have severe complications. So again, any activities that bring particularly the older members of the family or those who have chronic medical conditions together increases the risk of severe complications. So, the least would be to not do Thanksgiving at all, just stay with your immediate family this year. It's what my family has decided to do this year, is that we're just going to do our immediate family, and we don't have anybody coming in from out of town this year at all. So that's probably the least risky. If you do get people together, physically separate, keep your mask on, go outdoors if possible, separate, and remember the public health practices that reduce spread of the virus.
What's the projection for cases, hospitalizations, and deaths after the holiday?
Yeah, so that's why I put in the handout that will be distributed. The Institute for Health Metrics and Evaluation is predicting that by the first week or so after January 10th or so, they predict the highest impact in terms of hospitalizations in Oklahoma, with approximately more than 3,000 people in the hospital, which would be a doubling of where we're at today. I didn't look at their death projections, but again, the more people you have that are sick, the more people you have that require hospitalization and go into ICUs, the more people that you will have that will die of the disease.
How concerned are you about holiday travel? College students who could be traveling home for Thanksgiving next week. Do you expect a spike in cases the following week or two when they return in December?
Yeah, so I think we're really concerned about Thanksgiving in general, not just college students, but everybody, families traveling, coming together at this holiday. Because again, you know, you look perfectly healthy sitting across from me, but you could be infected right now. There's no way to know by just looking at a person, and they can feel fine, have no symptoms, and could be infected and could spread the virus. Our concern with college students, obviously, is that college students have a higher rate of being asymptomatic if they get the infection. And so across the state, we've encouraged college students to get tested before they go home, and if they're positive, please don't go home. We've told college students, if you feel ill in any way, even if you think it's a cold, the flu, or something else, please do not go around your family, and certainly don't go around family members who would be high risk for the complications of the virus. And then we at OU will be strongly encouraging those students who come back to the campus after the holiday, even though the coursework will be online, for those that do come back for whatever reason to the campus, that they test again when they come back, because one of our concerns was the rate of transmission of the virus on our campus has actually been quite low, but we know we're sending students home to many parts of the state that have high rates of transmission of the virus right now, and we're concerned that they could go get infected and bring it back to campus. So we'll be strongly encouraging testing when the students return after Thanksgiving.
What is it like seeing these large indoor social gatherings, like video from a church surfaced the other day of a concert where it appeared there was little distancing or mask wearing? How concerning is this to see as COVID cases rise, and should they even be happening right now?
Well, that's an easy one. No, they should not be happening. It's irresponsible. And the medical community is so frustrated that people aren't heeding the message that the virus is rapidly spreading through the population. So I don't know how many people were there, but again, if you consider that at least 1 in every 100 was infected, actively infected, not just had a positive test, but was actively infected, you can see how easily it would be to spread the virus in an environment like that. So many of us in the medical community have been calling on the faith community to help us out. Our hospitals are full, our healthcare workers are stretched. We've now changed nurse to patient ratios and things to try to take care of more patients. Please help us reduce the number of cases in Oklahoma. The faith community, we really need them to be on board with us to help slow the spread, even if it's a temporary intervention that we do for several weeks, such as Mayor Holt recommended yesterday. We need everybody in the community to help us slow the spread of this virus right now. And the way to do that is to encourage people to wear a mask, avoid these big gatherings of people indoors, which are well known to create circumstances for people to spread the virus.
Pfizer is seeking emergency use authorization for the vaccine today. What will the FDA be looking for to decide whether or not they will grant it?
Yeah, so I'm very, very happy that Pfizer will be applying for emergency use authorization, and I think Moderna, their RNA vaccine, will also be very closely following the Pfizer vaccine. The FDA will be looking at two principal things. Number one, is there evidence that the vaccine works? Does it actually prevent infections? And second, does it appear to be safe? Were there any noted side effects that would create concerns about safety? Remember, I think it's unfortunate that the term, quote, warp speed got attached to the development of vaccines, because this piece of it, the randomized trials testing the vaccine with placebo and vaccine in people, that hasn't been sped up. So there'll be more than 40,000 patients in each of these studies that will be presented to the FDA, and I think it's likely, based on the data, the preliminary data that's been released to the public, I think it's likely that we will see FDA give emergency use authorization to one or both vaccines. Now, that said, there's a couple of things that I think the public needs to recognize. Number one, this is very limited data. These vaccines have been in testing for only 3 to 4 months. So the trials will go on. They'll continue to follow the people that participated in these trials for long periods of time, looking for anything else that may come up that wasn't expected. But honestly, when you look at the number of people who are dying of this disease, the risk to benefit ratio seems to be low at this point. It seems that there's great benefit from getting more people vaccinated at this point to reduce hospitalizations and deaths from the disease.
Do you have faith in that process, even though it is emergency use, that the vaccine will be safe for the public?
Yeah, I feel comfortable. I actually have a close friend who works at the NIH, and they're very comfortable with the process that's being followed. Again, the manufacturers of the vaccine are following the typical approach that they would for any vaccine. That hasn't been compromised. The one thing we don't have, or we won't have, when these vaccines get approved is we're not going to have a year or 2 years or 3 years worth of data to know what's happened. It was highlighted in a meeting I was at yesterday. We've been making flu vaccines for 7 decades. 7 decades we've been making flu vaccines. These new vaccines have only been in existence and have only been tested for 3 to 4 months. So people who have enrolled in those trials will continue to be followed long term to see if anything else happens with the vaccine. The other thing to remember is there are multiple other vaccines that are currently in clinical trials. And I think, honestly, it's very likely in 6 months, a year, we're going to have a host of different vaccine options for COVID-19.
How do you get through to Oklahomans who still don't take this seriously?
Well, you know, we were talking about that on a conference call I was on just before I came over here, and my perception is that the general public is starting to take it more seriously, but it's principally because more and more people know somebody who's gotten really sick with the disease or has died from the disease. I see the stories in rural papers and rural communities around Oklahoma now of family members dying from COVID-19. It's becoming real to people as the virus has spread. So that said, there are still people that I don't think it's real. We need to encourage them to do it. Again, we think the action of just wearing a mask is a minor inconvenience, which will help stop the spread of the disease, potentially save the lives of the people around you, and potentially save your life. So it's just so very, very important that people understand that we're not doing this because we're trying to tell you what you should do, but it's the same reason, you know, that we've all been using seat belts for a long time, because it was proven over time that wearing a seat belt saved people's lives. Wearing a mask saves people's lives, and that's what we need people to do right now. When we get the vaccine available and we can get up to what we would consider true herd immunity by vaccinating a large portion of the population, then, you know, perhaps we can get away from these mandates for, you know, the need to wear masks and to physically distance. But we're not there yet. We have a ways to go.
Are we in need of convalescent plasma, and is that working on patients, and what therapies are being used?
Yeah, so there are a variety of therapies that are being used now. I'm very happy to report that I think some of the first patients in Oklahoma will start to receive monoclonal antibodies now. The monoclonal antibody drug, and I always get the name, it's Banlamivimab, has been shown to be effective when given to people before they get into the hospital. So if you have a high-risk individual, an older person, somebody that has a chronic illness that puts them at risk for the complications, and they're sick, but they're not so bad that they need to be in the hospital, those are the ideal candidates for that drug. You have to give it early to stop the virus from spreading and wreaking the havoc on the human body. So very happy to report that there'll be limited quantities of that drug initially, but it will be starting to be offered here in Oklahoma, and that's actually great news. Obviously, we're still using the drug remdesivir, which is an antiviral that's typically given to patients who are sick enough to be in the hospital. And then another drug, a rheumatoid arthritis drug, used in combination with remdesivir, was also just approved by the FDA. Convalescent plasma is still being studied. Again, it seems to be one of those interventions that if you do it, you have to do it early before the patient gets really sick, because if you wait until the patient is really sick, its usefulness is much, much less. So I know the Blood banks are still collecting convalescent plasma. And then finally, corticosteroids. Corticosteroids, drugs that we've had around forever, particularly for the really sick patients, reduced mortality by 30% in patients who are on the ventilator. That alone is very much worth receiving that therapy, because that's a substantial drop in the number of people that might die who require to be on the mechanical ventilator.
Do you think hospitals will reach capacity in the metro and across the state soon?
Yes, I think it's virtually inevitable. I've even told our leadership that I think it's inevitable. Again, with 20,000 new cases in a week, expect 2,000 of those people to need to be hospitalized at some point. I think it's just absolutely inevitable that hospitals will have to do more to make more capacity for COVID patients, which typically will mean reducing elective procedures, elective surgeries, and other things, converting units to COVID units, and perhaps even using hospitals that typically wouldn't be taking care of hospital inpatients, like rehab facilities, skilled nursing facilities, other types of facilities, to take care of COVID patients. I believe it's almost inevitable at this point that we will see continued increase in the number of hospitalizations.
Do you think we should do a 2-week freeze or shutdown similar to what Oregon and Mexico are doing?
Yeah, so I commend Mayor Holt on his request for people to do that yesterday. He highlighted that he needed everybody for 10 days to cut back, to avoid crowds, to avoid that. Wear mask. Don't go into settings where the virus is being transmitted. I think anything we can do to reduce transmission of the virus would be helpful. Many of the experts that I've talked to from around the country feel that partial lockdowns, shutdowns, limiting capacity in bars, restaurants, gyms, getting people in faith settings to wear masks are very, very important, and one of the few things we can do right now to reduce transmission.
And the last couple, what do you think the timeline looks like for the vaccine reaching Oklahoma?
Actually pretty quickly. So the one thing that I really like about Operation Warp Speed is that the companies that are testing their vaccines were given money to start making the vaccine even when they didn't know if they worked. So both Pfizer and Moderna have stockpiles of the vaccine, and I think it's likely that they'll be distributed fairly quickly once they get emergency use authorization. But please remember that the number of doses will be limited. They'll be prioritized to the frontline people that are taking care of COVID patients, like healthcare workers, doctors, nurses, emergency room staffing, respiratory therapy, the people who are really on the front line of COVID. That's where the priority will be. And then nursing homes, the really elderly, those that are likely to get sick and die from the disease.
And finally, the Pfizer vaccine needs to be stored at a very cold temperature, something like -100 Fahrenheit. What does that mean for local health departments, and will they need to order specific freezers in order to distribute that vaccine when it's available?
Yes, so it's my understanding that there have been 5 sites in Oklahoma that have been initially identified as being the points of vaccination, and that's explicitly because of that requirement to keep the Pfizer vaccine so cold. The Moderna vaccine doesn't have to be kept as cold, but it still has to be kept quite cold. But I think I heard Anthony Fauci this week highlight that these vaccines probably won't be the ones that get used in underdeveloped countries and others because they simply will never have that kind of capability to store those types of vaccines. And so again, there are multiple vaccines out there currently in clinical trials, and one of the important aspects of a vaccine that's useful is ease of administration. So that is going to be one of the challenges. Once you thaw the Pfizer vaccine, the vial of the vaccine, you have to use it within 6 hours.
Anything else you'd like to add?
Just remember, it's not too late to get your flu shot if you haven't had your flu shot, because there are influenza cases in Oklahoma, and we don't need any more people in the hospital with another respiratory virus.
Very good. Thank you very much.